adding Epcoritamab, which is a CD20, CD3 bispecific antibody, which engages T cells to attack lymphoma cells. The advantage there is that it increases the depth of response. And so it adds sort of a second way or third way. So if R squared, rituximab lenalidomide, has two ways that it's trying to kill the cancer cells. And this would be a third kind of way that it brings the T cells in and results in deeper responses. And based on the data that was presented at ASH, it results in responses that are deeper and hopefully more durable. So the bottom line is that hopefully it will allow patients to achieve a remission that is more prolonged. The 3-year follow-up of the S1826 trial, which is a landmark trial showing that adding Nivolumab, which is a checkpoint blocking agent, to chemotherapy is superior to brentuximab-AVD, which is a regimen that is also quite effective. It kind of, having that 3-year follow-up really confirms that this should be the frontline regimen that we're using for patients with stage 3 or 4 or advanced stage Hodgkin lymphoma. And the fact that it is even, the data indicates that it's even more effective in older patients is more reflective of the fact that it's often kind of a less toxic regimen that older patients would be able to tolerate. The challenge with treating older patients with diffuse large B-cell lymphoma is that most of our regimens are based on using pretty high dose or intense doses of chemotherapy, which, as you can imagine, in an older person is going to be harder for them to tolerate and will result in more toxicity. And so there is data that suggests that instead of using chemotherapy, if we can use some of these newer treatments like Mosunetuzumab or some of these bispecific antibodies, they may be less toxicity and so allow us to have less toxicity with hopefully as good or something close to as good of a response. Circulating tumor DNA is an emerging tool that looks for small fragments of tumor DNA floating around in the blood. And the advantage there is that it can detect at a much lower level than traditional response assessments like PET scans and CT scans. And so what it will allow doctors to do once it kind of becomes part of routine clinical practice is to see deeper, to see more, to use a microscope, if you will, to zoom a little bit more in and detect residual disease. And the hope is that by detecting residual disease or relapse disease earlier, we can act earlier to treat the patients earlier and ultimately improve their outcomes. Circulating tumor DNA is negative, your MRD is negative at the end of therapy. It's a good sign. It means that we don't detect any cancer in your body. But what some of the studies at ASH showed this year was that it's important to maybe check again. That checking once is good, that's a very good prognostic sign, but if you have multiple negative tests, it's even better.